Hello everyone. This is a second part of the development of the gastrointestinal system. So in this video I will be talking about the structures developing from the foregut and the related clinical aspects. The foregut, as I told earlier, extends from the buccopharyngeal membrane till the area where the liver bud develops. So that part is the foregut, which gives rise to different structures. So it can be divided into three parts. The first part mainly contributes for the pharyngeal apparatus. Okay, so associated with the pharyngeal arches is also called as branchial arches. So presently they use it as the pharyngeal arches. Okay, so the first part is the pharynx part. The second part is the thoracic part, mainly giving rise to the respiratory bud, which I had explained in my earlier video on the development of respiratory system, and also it gives rise to the esophagus. The third part is the abdominal proper, which gives rise to different structure, which includes a part of esophagus, stomach, and also the duodenum, and even the liver, pancreas, and the extrabiliary apparatus. So esophagus is a part of the foregut, which is at the thoracic part of the foregut, where there will be formation of an outgrowth from the ventral wall called as respiratory diverticulum or the lung bud. So this is the ventral wall and this is the diverticulum. Okay, so the part which is in connection with the foregut, where the respiratory diverticulum appears, so that part of the foregut will give rise to esophagus. So you had also known that how these two tubes are separated by formation of ridges on either side called as tracheo-esophageal ridges. So these tracheo-esophageal ridges, they move medially and fuse each other and then separates the two tubes. Ventrally has trachea and the lung bud, and dorsally the part of the foregut forms the esophagus. And this bud after fusion is called as tracheo-esophageal septum. Okay, so if there is abnormality in the formation of these septum, okay, or if there is incomplete fusion, so it can lead to different types of fistula and atresia, which also I had mentioned in detail in my previous video on development of respiratory system. So there can be isolated esophageal atresia. What do you mean by esophageal atresia? That is a complete closure of the esophagus. There is no connection. Okay, it can happen either at the upper end of the esophagus or at the lower end of the esophagus, or sometimes there can be esophageal atresia associated with fistula, which is called as tracheo-esophageal fistula. So there are different types which I have explained in my previous video on development of respiratory system. So whenever this condition is there, esophageal atresia with tracheo-esophageal fistula, so usually the mother will suffer from a condition called as polyhydramnios. So what do you mean by polyhydramnios? There is increase in the level of amniotic fluid. So you know that amniotic fluid is very much necessary, though it forms a cushion around the developing embryo. Even a part of amniotic fluid is swallowed by the fetus, which is very much necessary for the development of the lungs, for the conditioning of the respiratory muscles. Also, it is necessary for other organs to develop. So, this amniotic fluid, which is swallowed by the fetus, maintains the amount of amniotic fluid surrounding around the embryo. Okay, so if there is esophageal atresia at the upper part of the esophagus, so what happens? Whatever amniotic fluid is swallowed by the fetus, it is regurgitated back. So what happens? There will be increase in the amount of the amniotic fluid, and this condition is called as polyhydramnios. Usually there can be esophageal atresia and tracheophageal fistula in the fetus, and the mother can have polyhydramnios. Sometimes this can be associated with other defects like cardiac defects, or there can be defects in the kidney. Okay, so this can be, if there are defects in many organs, so this can be called as a syndrome. Before I start with the development of the stomach, I would like to discuss a case A 5-week-old male neonate presents to the emergency department with his parents. Parents report a 2 days history of projectile vomiting. So what do you mean by projectile vomiting? There will be immediate forceful, once you feed the baby, there will be immediate forceful vomiting, okay, the expulsion of the food products, okay. So there is no history of fever, diarrhea or constipation. Mother denies bilious, that is the greenish colored particles. The vomiting was not greenish colored, greenish yellow in color, okay. Mother denies bilious or bloody emesis. Physical examination reveals normal vital signs with no distress. The abdomen is soft, not distended, non-tender and no palpable mass felt. Ultrasound showed the pyloric muscle to be abnormally thickened. The neonate was admitted to the hospital for rehydration and a surgery was done. So this case is related to the development of the stomach, which you will be coming to know the reason behind this once we will discuss the development of the stomach. So the stomach develops, as I told earlier, foregut is divided into 3 parts. The pharynx part giving contribution for the pharyngeal apparatus. Thoracic part, mainly the esophagus develops and also contributes for the development of respiratory diverticulum, okay. And the abdominal proper, the abdominal part mainly gives rise to one of the structures is the stomach. So there will be fusiform dilatation at the foregut, the abdominal part of the foregut, okay. So this fusiform dilatation initially exactly at the midline you will see these dilatation. So the development of the stomach undergoes different variations. So this fusiform dilatation you see exactly approximately at the 4th week of development. On further development, okay, on further growth in the future weeks, so what happens, there will be variation in the position and also in the rate of growth. So this is due to the rotation occurring within the stomach, okay, and also due to the difference in the rate of the growth. For this I would like to use a book so that you will understand the rotation of the stomach easily. Imagine this is a tube, the abdominal part of the tube, okay. So there is a fusiform dilatation on either side, okay. So this is the anterior border, okay, posterior border or anterior wall, posterior wall. This is the right side surface and this is the left side surface. So the stomach rotates clockwise, okay. So stomach rotates clockwise 90-degree rotation, okay. So it undergoes 90-degree rotation on clockwise direction, okay. If you see from the front, it undergoes 90-degree rotation clockwise. So the surface which was on the left side now forms the anterior surface and the surface which was there on the right side will form the posterior surface. So the stomach, once there is fusiform dilatation, it undergoes 90-degree clockwise rotation where the left side surface forms the anterior wall, okay, and the right side surface forms the posterior wall, okay. Later this was the anterior border, okay. Now it forms the right side. The posterior wall or the posterior border forms the left side, okay. So this is how the rotation occurs. Later what happens, due to the difference in the rate of growth, so what happens, the original posterior wall, this was the original posterior wall, after rotation it has become the left side, okay. So the original posterior wall undergoes more growth when compared to the original anterior wall. I am stressing here original because initially this is the anterior wall. Now it has changed due to the rotation, okay. So the original posterior wall grows more, okay. The grows more when compared to the original anterior wall. So due to the difference in the growth, so what happens, there will be formation of a curvature since this has grown faster than the anterior wall. So this forms the greater curvature of the stomach and this forms the lesser curvature of the stomach. So this was a fusiform dilatation initially due to the rotation. So on longitudinal axis, the stomach rotates 90-degree clockwise, where the left side becomes the anterior wall and the right side becomes the posterior wall, and the original posterior wall grows faster compared to the original anterior wall. So there will be formation of greater curvature on the left side and lesser curvature on the right side. Then initially the cephalic and the caudal end, this is a cephalic end and this is the caudal end, cephalic end and the caudal end. Initially it will be in the midline. Due to the difference in the rate of growth and rotation, the caudal end will move towards the right side of the body. So this forms the pyloric part of the stomach, and the cephalic end moves towards the left side of the body, and this forms the cardiac end of the stomach. So this is how the stomach develops. So this is the cardiac end, move towards the left side. The caudal end, which is the pyloric end, move towards the right side. So this is how the position, the final position of the stomach takes place. Since due to the rotation, so initially the vagus nerve is the main nerve which supplies the organs of the abdominal cavity. So the vagus gives two branches, one is right branch and one is the left branch. So after rotation, as I told earlier, the left side becomes the anterior wall. So due to the rotation, you can see here, so there were two branches of the vagus, right vagal branch, left vagal branch. So due to the rotation, so you have seen in some of the textbook gross anatomy of the stomach, they mentioned the stomach is supplied by anterior vagal trunk and posterior vagal trunk. So initially, embryologically, they are called as right vagal trunk, left vagal trunk, and once after the final position takes place, so the left vagal trunk is called as, since the left side of the surface forms the anterior wall, so the left vagal trunk will be called as anterior vagal trunk and the right vagal trunk will be called as posterior vagal trunk. Okay, so both are one and the same. Okay, the right vagal trunk forms the posterior vagal trunk after the rotation, and the left vagal trunk will form the anterior vagal trunk after the rotation. So please remember, stomach rotates 90-degree clockwise direction. So now coming to the layers in the stomach, as I told earlier also in the general features and general layers of the digestive tract, the endoderm part gives rise to the epithelium and the glands present in the stomach. Okay, gastric pits where there are different glands and cells like chief cells, parietal cells, all those cells. So all those cells are derived from the endoderm layer. Okay, then the splanchnic mesoderm will give rise to the connective tissue which are called as serosa. Okay, then the smooth muscle, the muscularis interna and externa, then the blood vessels. So all these structures are derived from the splanchnic intraembryonic mesoderm, and also there is a contribution from the neural crest cells. Okay, which gives rise to the autonomic nerve plexus. So there are different mesenteric and submucosal plexus within the layers of the stomach. Okay, so those autonomic nerve plexus are derived from the neural crest cells. So this is the contribution, the layers, so which are contributing for the different structures of the stomach. So due to the rotation which occurs in the stomach, that is 90-degree on the longitudinal axis on the clockwise direction. So what happens, as I told, the gut tube, so you can see here, so this is the right side and this is the left side. So due to the rotation in the stomach, so the dorsum mesogastrium will move towards the left side, forming a cavity posterior to the stomach. Okay, so there will be formation of a small sac or a cavity or a bursa due to the rotation of the stomach. Okay, so this bursa is called as omental bursa, also called as lesser sac. So initially there will be one sac. So once you open the abdominal cavity, the sac which you see, the cavity which you see is called as a greater sac. Okay, but due to the rotation of the stomach, the dorsal mesogastrium is pushed towards the left side. Okay, so this results in the formation of a small sac just behind the stomach, posterior to the stomach, okay, which is called as the lesser sac or omental bursa. Okay, so here you can see this is a cut section, the transverse section you can see, and if you see from the above, so this is the developing liver. Within the ventral mesentery, this is the ventral mesentery. Within the ventral mesentery, there will be development of the liver, okay, which I will be discussing later. This is the stomach, which is covered by from the posterior wall and the anterior wall. Then you can see this is the dorsal mesentery. Okay, once the rotation occurs, there will be formation of omental bursa or the lesser sac. So this dorsal mesentery, you can see here, it is attached to the dorsal body, the posterior abdominal wall. Okay, so within the dorsal mesentery, due to the proliferation of the mesoderm, there will be development of spleen. Okay, so there will be appearance of spleen primordium due to the proliferation of the mesoderm within the dorsal mesentery, are suspended by mesentery. Okay, since the foregut has mesentery both on the ventral aspect and the dorsal aspect, so the mesentery attached to the stomach will be called as dorsal mesogastrium and ventral mesogastrium. So due to the rotation on the longitudinal axis, okay, so the dorsal mesogastrium will be pushed towards the left side. Okay, so due to the formation of the spleen, so what happens? The spleen also will be covered with the peritoneum or the dorsal mesentery, because spleen is arising. Okay, they are appearing within the dorsal mesentery, within the two layers of the dorsal mesentery. Okay, so this you can see here, the posterior leaf. Okay, the posterior leaf of the dorsal mesentery, which is attached to the posterior abdominal wall, will be now attached to a structure which is appearing here called as left kidney. Okay, there will be formation of left kidney here. So the posterior leaf, because as I told, these peritoneum layer are two layers. They have anterior leaf and the posterior leaf. So initially the posterior leaf will be attached to the spleen will be developing in between these two leaves, and the posterior leaf initially will be attached to the posterior abdominal wall. Okay, since there will be development of the kidney behind the posterior leaf, okay, the left kidney develops here. So this posterior leaf will no longer be in connection with the posterior abdominal wall. It disappears and directly it will be connected to the left kidney, which leads to the formation of two ligaments called as lino-renal ligament and gastrolino ligament. Okay, so you can see here, here in this they have mentioned two ligaments here. Ligaments is nothing but the mesentery, the peritoneum, okay, which is connecting from one organ to the other organ, or from one organ to the posterior abdominal wall, okay, or to the ventral abdominal wall. So ligaments are nothing but, as I told, the peritoneum are given different names. In some parts they are called as a mesentery, mesocolon, mesogastrium, or sometimes it is called as ligaments. So what happens? There will be formation of two ligaments of the posterior aspect of the stomach. So you can see one of the ligament, that is dorsal mesentery, connecting the stomach to the spleen, is called as gastrolenal ligament. Lenal is nothing but the spleen, okay, because it is connecting the posterior aspect of the stomach to the spleen. Gastrolenal ligament, and from spleen to the kidney, left kidney, so this is called as lino-renal ligament, from one organ to the other organ. So lino-renal ligament. So there will be formation of two ligaments on the posterior aspect of the abdomen, and also there will be formation of a bursa or a sac called as omental bursa or lesser sac. On the ventral aspect, I had told earlier, the ventral mesentery, due to the development of liver within the ventral mesentery, there will be formation of two layers, lesser omentum between the stomach and the liver, and falciform ligament between the liver and the anterior abdominal wall. So this is called as falciform ligament, which is mentioned here, falciform ligament and lesser omentum. The this picture is showing the rotation of the stomach. So this is the stomach. Okay, this is the dorsal mesentery, ventral mesentery. So the rotation is occurring. So this will move, the dorsal mesentery will move towards the left hand side and the ventral mesentery towards the right hand side. So once the rotation is complete, there will be formation of a small sac called as lesser sac. Okay, so this is the developed spleen. This is the stomach. So this ligament is called as gastrorenal ligament, and this is lienorenal ligament. This is the left kidney. There are some organs which develop within the peritoneum. These are called as intraperitoneal organs, which include stomach, liver, spleen. Okay, they develop within the peritoneum. There are some structures which has peritoneum only on the anterior aspect. Posteriorly, they don't have any peritoneum. They are in connection with the posterior abdominal wall. So these are called as retroperitoneal structures or retroperitoneal organs. This is the ligaments which I mentioned, formed in the dorsal mesentery and in the ventral mesentery. As the stomach develops, this is the anterior leaf of the mesogastrium. This is the posterior leaf of the mesogastrium. Okay, so this leaf will form a sleeve or an apron like structures in the anterior wall. Okay, so they elongate and they grow further and they form a double sheet structures which has 4 layers. You can see here, this is initially during development. They form a long sleeve. Okay, so this sleeve covers the transverse colon and even the small intestine, loops of small intestine. So they cover that and they form a double sheet having 4 layers. You can see here 1, 2, 3, 4. So initially there will be 4 layers. They form a double sheet and this long sleeve is called as greater omentum. Okay, so behind that, this double sheet, there will be a small cavity covering called as omental bursa or the lesser sac. So as the development takes place, so what happens, these 2 layers which is in connection with a mesocolon. So this is the pancreas, this is the duodenum, this is the transverse colon, and the mesentery covering the transverse colon is called as mesocolon, and this is the loops of small intestine covering that will be called as the mesentery or the mesentery proper. Okay, so these 2 layers, they fuse each other to form a single sheet. So initially there will be double sheet with 4 layers. So these 2 layers, they fuse each other forming a single sheet having only 2 layers, and the greater omentum will be directly in connection with the transverse mesocolon. So initially there will be double sheet with 4 layers. The 2 layers will fuse each other and there will be formation of single sheet. So once you open the abdominal cavity, you see the greater sac and you will see a long apron like structure covering the yellowish, which is filled with fat, which is called as the greater omentum. So once you reflect the greater omentum, since it is in connection, attached to the transverse mesocolon, you can see the transverse colon. So once you lift here, you can see the colon, the transverse colon covered by the peritoneum, which is called as transverse mesocolon. So this is how the omentum and how it is connected to the mesocolon. Coming to the clinical aspects, so before I started the development of the stomach, I had discussed a case. 5-week-old baby came with the complaints of projectile vomiting. So you know that at the pyloric end, the epithelial layer they are derived from the endoderm, and the connective tissue muscle layer is from the splanchnic mesoderm. Okay, due to the overgrowth of the muscular layer in the pyloric end, so there will be narrowing of the lumen of the pyloric region. So this is called as pyloric stenosis. There will be overgrowth of the muscular layer which narrows the lumen, the pyloric part of the lumen. Stenosis is narrowing of the lumen. Atrasia means complete closure. So here this is very common, the pyloric stenosis. Atresia also can occur, but most common one is the pyloric stenosis, where there will be narrowing of the lumen. Okay, there won't be much space for the food or the liquid to go down into the small intestine, into the duodenum. So what happens, once the fetus starts feeding, there will be regurgitation, and that leads to projectile vomiting. So whatever the food enters the stomach, okay, will regurgitate back, and that leads to projectile vomiting. Projectile vomiting is the important sign of pyloric stenosis. Since it has not entered the duodenum, the whatever food particles which are emitted out in the vomitus, it won't be stained, it won't be greenish in color or yellowish green color. That's why it was non-bilious, because the bile secretion is mainly at the duodenal region. So since it has not entered the duodenum, it is within the stomach. So whatever the color of the vomitus will be the food particle only. Okay, it won't be greenish yellow in color, or sometimes it doesn't have a bloody tinge also. So this condition is called as pyloric stenosis. Now coming to the second case, a female infant was born prematurely at 32 weeks gestation to a 39-year-old woman whose pregnancy was complicated by polyhydramnios. So I told what is polyhydramnios, increase in the amount of amniotic fluid. The baby began to vomit within few hours after birth. The vomitus contained bile. Marked dilatation of the epigastrium also was noted. So radiographs of the stomach showed gas in the stomach and superior part of the duodenum, but no other intestinal gas was observed. So what was this case? So here you can see there is a difference. There is vomiting, but the vomitus contained bile. Okay, so what is this case? You will come to know once we discuss the development of duodenum. Okay, so duodenum, again, it develops from the abdominal part of the foregut and also from the midgut. So duodenum has a contribution. Duodenum develops from two structures, one half of it from the abdominal part of the foregut and the remaining half is from the midgut. That's why when you see the blood supply of the duodenum, it gets branches both from the celiac trunk and also from the superior mesenteric artery, because it is contributed by both by the foregut and also from the midgut. So this part, it's shown with the arrow, derived from the distal end of the foregut, okay, and this part is from the proximal end of the midgut. Due to the rotation of the stomach, the duodenum also undergoes slight rotation to the right side and they form a C-shaped loop. Once the stomach rotates 90 degrees on the longitudinal axis, duodenum also undergoes rotation to the right side, forming a C-shaped loop, okay, having different part, first part, second part, third part and the fourth part. Since they are derived from both from the foregut and midgut, it receives dual blood supply from the foregut and midgut, that is from the branches of celiac and the superior mesenteric arteries. So when you see the mesentery attached, as I told, even the duodenum has been derived from the foregut and the midgut. Even they have been suspended from the dorsal and the ventral mesentery. Ventral mesentery is not much, but mainly it is suspended from the dorsal aspect of the dorsal mesentery. So what happens? It loses its mesentery. Okay, it is pushed towards the posterior abdominal wall due to the midgut rotation. Due to that, the duodenum is pushed towards the duodenal wall and it later becomes retroperitoneal structures. So duodenum is considered as secondary retroperitoneal organ because initially it was intraperitoneal. Due to the development changes, it has become retroperitoneal. There are some organs which are initially they are retroperitoneal. For example, kidney. They develop in the posterior abdominal wall and they are covered by the peritoneum only on the anterior aspect. So these the kidneys are called as primary retroperitoneal. So since the beginning they are retroperitoneal. But duodenum and pancreas, due to the further changes in the development, initially they will be intraperitoneal, but later they become retroperitoneal. So that's why they are called as, since it loses its mesentery, so they later become secondary retroperitoneal organ. That means they have the peritoneal layer covering only on the anterior aspect. When you see the lumen of the duodenum, okay, so this is the lumen of the duodenum. So this is the epithelium. Okay, the epithelium undergoes changes and there will be proliferation of the epithelium. So initially this is at the 4th week. So at the 8th week there will be complete closure of the lumen due to the proliferation. Okay, the epithelial cells, they undergo proliferation. Okay, and they completely close the lumen, which is at the 8th week. At around 10 weeks, what happens? The recanalization takes place by apoptosis. Apoptosis is the natural cell death. Okay, so what happens at the 8th week? There will be closure. Okay, there will be closure of the lumen. By about 9th week, the cells undergoes apoptosis and there will be recanalization and there will be formation of the final epithelium at around 10 weeks. So at the 4th week, initially the epithelial cells will be present. They undergo proliferation at the 8th week, and by 9th week there will be apoptosis resulting in recanalization. So this is an important step in the development of the duodenum. If the recanalization doesn't occur, that results in duodenal stenosis. Or if there is complete absence of recanalization or complete absence of apoptosis, so what happens? There will be closure of the lumen. So that condition is called as duodenal atresia. So here in the duodenum, atresia is very common because they are undergoing different changes. There will be proliferation of epithelium, there will be closure and again recanalization which is occurring. So what happens? In pyloric area, pyloric stenosis is very common. But in the duodenal area, duodenal atresia, there will be complete closure of the lumen. So what happens? So in the duodenum, as the food particles which are taken, they enter the duodenum, a part of the duodenum, but that's what, there is no projectile vomiting. What happens in the pyloric stenosis? There is projectile vomiting because it takes time for the food particles to enter the small intestine, the duodenum. But here in pyloric stenosis, the stenosis is at the stomach region. So what happens? The vomiting will be immediate and it will be projectile, forceful. But here what happens? Since the atresia is in the duodenal region, the food particles takes time till it reaches the duodenum. Once there is atresia there, then the vomiting occurs. So there is a time gap between the swallowing of the food particles and the vomiting. There won't be projectile or forceful immediate vomiting in duodenal atresia. So these are some of the signs where you can differentiate whether it is pyloric stenosis or duodenal atresia. So you can see this is an ultrasound picture showing the gases, filled with gases, okay, in the duodenum and the stomach. So the food particles have not entered, just there are some of the gas bubbles filling the stomach and the upper part of the duodenum. So this is a condition called as duodenal atresia.
Completes the embryology of stomach, esophagus and duodenum. Watch my next video for the development of liver and pancreas.